Hi, welcome back to the Doodler, and today we are going to be talking about depression, and we're going to be talking about the theories behind depression, and we're going to be talking about what are the symptoms of depression that the DSM-5 uses to diagnose people, and just all things related to depression. So just going in, depression is a mood disorder, and it is defined in the DSM-5. You need to have either a depressed mood or apathy / lack of interest and pleasure in doing things. And then, so one of these, and then you need 4 of these guys here. So 4 of those. And these can include weight, appetite changes, sleep disturbances, fatigue, guilt, worthlessness, executive dysfunction, suicidal ideation, and then slowed cognition is also one of them. So depression is also called unipolar depression because there's also bipolar depression, in which patients can either be bipolar 1 and 2, and in that case they would have symptoms of mania or hypomania, which would be its own thing. So we're going to talk about that in a different video and go over the types of bipolar depression as well. So underlying, though, the unipolar depression or just depression in general, there's 2 main theories that are commonly cited when considering like what causes depression and why the medications that we use to treat depression may work. Because even though like people take medications for depression, they didn't actually know, like researchers didn't know what was in the medication that was making the symptoms better. And so it was actually kind of like a reverse type of situation where they figured out that serotonin had something to do with depression, because when given a drug that increased the levels of serotonin or other monoamines, the patient experienced less symptoms. So the 2 theories that we're going to talk about today are the monoamine theory and the neuroplasticity theory. And they're really linked now. Like they don't stand on their own. So starting with the monoamine theory states that depression is due to an imbalance in the monoamine levels present in the brain. And typically the monoamine theory states that a patient who's depressed has low levels of monoamine, which causes a compensatory upregulation of receptors on the postsynaptic membrane. So what this would look like is if we have dopamine right here, there would be an increase in receptors on this postsynaptic membrane because there would be low levels of dopamine released. And it's thought that this imbalance in the ratio of receptors to monoamine is what causes depression, and that's what the monoamine theory states. But there's no direct evidence for this. There is some studies showing that like people who committed suicide had higher levels of receptors for some specific monoamines, but really like it's not enough to say that there's not enough evidence showing that just because you have low levels of monoamines that you will have symptoms of depression. So that's when the neuroplasticity hypothesis comes in. So I'm just going to edit these real quick and just add what it would look like. So this would be high upregulation of the postsynaptic membrane receptors. And in my other video where I talk about how antidepressants work, like SSRIs, SPRIs, and SNRIs, I go through like how these receptors are downregulated with those medications. Oh, excuse me. So now, how do we know that the monoamine theory is incorrect? Well, because if it was simply just low levels of monoamine equals depression, then when given a SSRI, the patient would immediately see all of the beneficial effect within the first couple of days of taking the drug, because the drug can quickly increase the monoamine levels. But most people seen clinically, the full effects of a drug take almost a month to be observed. So this means that there's something else going on besides just like the increasing levels. So I'm going to just go talk through this diagram here. So this diagram shows that at 0 minutes, 20 minutes, and then 3 to 4 weeks, so the time is not to scale, but this is time, patients, this gives like an example of like what's going on in terms of just like scale. So this first blue color is the amount of receptors on the postsynaptic membrane. So you can see this is in a depressed patient. So here there'd be a high level of receptors on the postsynaptic membrane, but here is after treatment with a antidepressant. So there's less. Next is the amount of monoamine. So within 20 minutes, there's an increase in the amount of monoamine present in the body once given. This is at time 0, you're given an SSRI or one of these psychiatric medications. So there's a direct increase. But if the increase directly caused depression, like just having a low amount, then we would see this green line here. This is the hypothetical result. You would see this huge spike, basically almost like following this one, and then they would both be increasing really quickly towards this like asymptote, that there would be a really quick improvement, and it wouldn't take 3 to 4 weeks to improve because it doesn't take that long for the levels of monoamine to increase from the drug. So what we actually see is this yellow line here. And this yellow line shows that at around, like, I would say, like 1 to 2 weeks, you kind of have half of the result. And then at 3 to 4 weeks, you're getting, like, the full result. Whereas here, it's kind of like almost within the first week, you're hitting the full effect of the drug. So this is how we know that the monoamine theory is not the full story. But it definitely has some merit because it does alter the ratio of receptor to neurotransmitter. So that leads us to the next theory, which is the neuroplasticity theory of depression. And this theory states that when you have a patient that is depressed, they have lower levels of neuroplasticity and long-term potentiation and neurogenesis and synaptogenesis. And this is all due to a decrease in BDNF. And this decrease in BDNF is caused by things like stress and poor immune system, or like chronic immune conditions, and environmental factors, and sleep and inflammation and early life adversity, faulty genes. So all these things can influence BDNF gene being turned off. And BDNF stands for brain-derived neurotropic factor. And this factor, when expressed, leads to neuroplasticity, neurogenesis, cell survival, and synaptogenesis. So it's thought that in depression, this transcription factor is turned off, and now it leads to all of the symptoms associated with depression. So that would look like, here's the first step in the pathway. So a monoamine comes in. So by directly increasing the level of monoamines in this, like the correct ratio of monoamines to receptors, you would get a better activation of this pathway here. So you'd get activation of step 1 and then 2, so cyclic AMP, and then 3, this one, and then you get cyclic AMP response element binding protein, and then that would activate BDNF, which will lead to cell survival, synaptogenesis, neurogenesis, and neuroplasticity. And so that is why having an imbalanced level of monoamines, or the receptor to monoamine levels, could cause like the symptoms of depression. And this part right here takes a lot longer than just 20 minutes. Like changes to cell signaling and transcription are going to take a lot longer, like days to weeks, which is why the neuroplasticity hypothesis of depression and then monoamine hypothesis of depression both go together to better explain the effects of the drugs that we see when given clinically. So I just mentioned these. So what things cause BDNF not to be expressed? So we said, so lack of sleep, chronic inflammation. And this is just important to know because this explains why people with like health adversity or just adversity in general, it's not health adversity, sorry, early life problems, stress, your microbiome, faulty genes, so all these things together can cause BDNF not to be expressed. And overall, depression, when untreated over time, because BDNF is not going to be expressed, would result in neuronal spine degradation, degeneration, which would lead to cognitive decline, structural brain abnormalities, vulnerability to treatment resistance, and damage to synapses and neurons. Okay, so that's all for this video. My next video is going to be about ADHD, but I would highly recommend going back and checking out the video I did on SSRIs and SPRIs and SNRIs to better explain the brain receptors. And then also, I would just like to give a shout out to Stahl Psychopharmacology. A lot of the basically all the information I'm presenting here is presented in that textbook. And then also the song that I played at the beginning is from the Chapel Roan song, Naked in Manhattan. So yeah, I do not claim the right to that music bite, but anyway, thanks for watching my video, and hopefully this helped explain the difference between the monoamine theory, depression, and the neuroplasticity theory. And the big takeaway is just that the monoamine theory focuses on the imbalance of monoamines, and there are a number of receptors, versus the neuroplasticity theory looks at the effect of those lower levels of monoamines causing problems with activating CREB, and then BDNF, which BDNF is known to cause when expressed, causes cell survival, neurogenesis, synaptogenesis, and neuroplasticity. So when you remove the BDNF, you now have all these other problems that can lead to symptoms of depression, as stated in the beginning. So yeah.